Good morning, everyone. 6:30. We're going to go ahead and get started with Grand Rounds. We have Dr. Meagher speaking today and Dr. Bolger introducing.
Well, good morning. It's really my honor to introduce my good friend, Dr. Ashley Meagher. Dr. Meagher actually trained with us as a trauma critical care fellow back in 2017, then went off to the University of Indiana, where she served on the faculty. Um, while she was a fellow, Dr. Meagher was part of our UW Comfort Care Quilt Program, which is a group of volunteers that make quilts for all the hospitals for patients at end of life. So she's had a long-standing commitment to palliative care. And when she went to Indiana, she actually founded the Indiana program, mirroring the UW program for comfort care quilts. So we were very excited about that, and we've kept close as a result of that. Sadly, while in Indiana, she suffered her own personal interaction with hospice and palliative care that she's going to share with you today. And that made her think a little bit about her career. And she's back here now doing a palliative care fellowship. So just finished the palliative care fellowship. So uh, she has a great perspective on the issues of caregiving and what our patients are going through, and sometimes what we are going through and taking care of loved ones. And I thought it was really valuable for us to hear that in the Department of Surgery. So welcome, Ashley, and we're excited to have you.
Thank you so much, Dr. Bolger. Let's see if I can make this advance. Oh, there we go. As someone who just finished my palliative care fellowship, it has been a long time since I've been on this side of 7 a.m. So thank you guys for being here and those who are online. I am really excited to be back here, and I actually was just talking with our coordinator for the comfort care quilts in Indiana. They're doing an amazing job over there, and I'm just so grateful to Carol Kuma and the comfort care quilt group here for all the support they gave me setting that up. So this is going to be a very atypical surgical grand rounds. Much of this talk is based on my personal experience. There is not a lot of science. There are gratuitous pictures of my mother, husband, and my pets. So, you just get to be subjected to that. I have no financial disclosures. And just for introduction, this is Ricky, the dog who was a COVID dog, Willow, who we'll hear a little bit about, and then Jasper, who was our former cat. He has now passed. Just the objectives of this talk are to describe the indications for palliative care involvement in general, a little bit more specifically for surgical patients. Describe the hospice experience. There's not a lot of people who do that. And we talk to patients about hospice quite a bit. I know I did it in residency. I know I did it as an attending, and I had absolutely no understanding of what I was talking to them about. And then just to give you guys some communication strategies to think about while working with patients and their families at the end of life. So just to get everybody on kind of the same wording page, one of the things that I hear a lot is patients are on palliative care, or palliative care is involved. And I think there's a lot of kind of misuse of or misunderstanding of how palliative care works. So palliative care is actually an interdisciplinary subspecialty of medicine. It is boarded. You can get into it through family medicine, surgery, or medicine. The aim of palliative care is to improve the quality of life by mitigating suffering and stress. It works with patients and families to understand their choices in their medical care. Palliative care involvement does not depend on prognosis. Patients can still be treated with curative intent. So I really think that's a big misnomer, is that patients who have a palliative care consult or in palliative care is involved means that they're not getting treatment anymore. That's not true. That's still curative intent. And palliative care is really optimal for persons with serious, chronic, or life-limiting disease diagnoses, which in surgery is a lot of the patients that we deal with. So as an example, you have a 70-year-old woman who arrives in clinic with a new diagnosis of non-small cell lung cancer. She's a lifelong non-smoker. She's very active, walks 2 to 5 miles a day. Her only symptom is dry cough and unexplained weight loss. Immediately, she's scheduled to meet with oncology, radiation oncology, and surgery. Immediately, I'm sure you're thinking about recommendations. What are you going to offer this person? And this is my mother. So just a full disclosure. This was her diagnosis in February of 2020. Primary palliative care is what surgeons really should excel at. And it's really something that needs to be part of a surgeon's toolkit. Asking a patient, what is most important to you? What do you want from your treatment? What are your goals for the end of your life, be it soon or years from now? How are you handling your diagnosis? And how can we help? These are not questions we hear very often in our very busy clinics when we're seeing new patients with new diagnoses. But I would posit, how can a surgeon or a physician make an informed recommendation without knowing what's important to the patient? Where does the patient get their strengths? What are they worried about? What do they enjoy doing? When was the last time they were able to do what they enjoyed? If they could no longer do the things they enjoyed, would life still be worthwhile? Is there any point when life would not be worthwhile? And what do patients think that would look like? Like I said, I have very few science slides, but we do know that palliative care actually reduces spending and utilization in all settings. It decreases readmissions, cost per day for inpatient stays. It decreases ED visits and decreases admissions from the ED. It decreases hospital and ER transfers in a skilled nursing facility setting. And it decreases total costs for patients who are being cared for at home. And so when you're thinking about what is a patient going to undergo, what are they going to need? We're not doing it, we're doing it for the patient's benefit, but also we have to think about the healthcare system and the medicalization that patients end up going through. There's actually a very good study. This came out actually while I was still in training, but early palliative care for patients with metastatic non-small cell lung cancer. And surprisingly, the patients who received early palliative care consultation had less aggressive care at the end of life, but also had longer survival. And this really led to some of the recommendations by the American College of Surgeons and the National Cancer Institute to have early palliative care involvement in oncology patients. But it really, remember, it leads to significant improvements in both quality of life and mood. And I'd like to dispel, I think that a lot of times people think of palliative care as a bad word. Oh, we're getting palliative involved, we're giving up. Oh, palliative's going to be involved so that they can make the patient DNR. Palliative's going to get involved and talk this patient out of the operation. That's not what palliative care is involved in. The goal is to talk to patients and honor what the patients want and help the patients realize the decisions that are best for them. And there really does seem, unfortunately, to be an idea that curative and palliative are widely different spectrums or parts of the ends of the spectrum. but I argue that they really are one and the same, and they just open the door for a better care plan and a better course of care for the patient and, frankly, the physician. So returning to our patient, imagine that now she is scheduled to meet with oncology, radiation oncology, and surgery, and either palliative care or a primary palliative care conversation by the teams is included in the plan. So what if at diagnosis, the first conversation included some of these primary palliative care questions that I gave y'all? Does she need a referral to palliative care? If she's very clear on her goals and a clear path forward is set, then she may not need a referral to palliative care. It's just someone needs to hear her give these answers. And I wonder, why isn't palliative care equally as involved as the other three services? We talk about goal concordant care very frequently. So we want to provide the patient with healthcare that aligns with their values and goals, helps the patient make a choice in healthcare that is right for them, and balancing over treatment as well as under treatment. And so let's do a little thought experiment. So what if the patient reports valuing quality of life over everything? Does not want to spend any time in the hospital, and she would like to focus on comfort for her remaining days. Imagine that you're the resident or the surgeon in clinic, and these are the things that she's saying as you're doing your primary palliative care questions. Your treatment recommendations likely change. Perhaps refer her to palliative care, consideration and explanation of hospice, prioritize comfort, and provide community resources. But what if she says, I really value my quality of life, but I also love living and I want to continue traveling as much as I can. I'm okay with trying to go for a cure if a cure is possible. And I think I'd be okay with undergoing systemic treatment. I'd like to hear more about that. With the caveat being that my quality is the most important thing. Perhaps she proceeds with neoadjuvant treatment. Perhaps we offer minimally invasive surgery with a plan for, aborting the surgery if unable to complete minimally invasively. Adjuvant immunotherapy, and then consider palliative care if her symptoms become significant and beyond the ability to care for in the surgical or oncology clinic. And what about if the patient reports valuing quantity of life over anything? She wants to be aggressive and try everything for a cure. Well, we proceed with treatment. Perhaps we enroll her in a trial for new medications. We plan for aggressive surgical intervention, and we do adjuvant immunotherapy as well. All three of these recommendation paths are completely viable and valid for a patient, but they may not be, each path may not be correct for, a single patient. I think a lot of times we sort of treat it as a one size fits all. The surgical recommendation is X, and we move our path forward, no questions asked. And the thing is that these are very different patients. How do surgeons intersect with palliative care? The majority of surgical patients have a serious diagnosis. 17% of surgical inpatients die within 1 year. 1/3 of Medicare beneficiaries undergo surgery in their final year. And we know that the majority of spending at the end of life is in the final year of care. 1/5 of patients have a surgical procedure in their last month of life. And the majority of surgical patients do not receive a palliative care consult. Are we doing the right things for our surgical patients? Now we're going to transition. What happens when a patient no longer wants life-sustaining treatment? I've talked about palliative care and how it is concordant. You can do it in concordance with life continuing care or curative treatment intent. Hospice care is different. It's what we bring in when patients have a prognosis of 6 months or less. You cannot be utilizing curative treatments. Hospice is not a place. It occurs wherever the patient is, be that in the hospital, in a nursing facility, or in a home. It is paid for by Medicare, Medicaid, and insurance. Hospice is the end of the palliative care spectrum. It has in common with palliative care optimizing comfort, reducing stress, relieving symptoms, and providing emotional and spiritual support, but is clearly when the goals have changed. It focuses on the palliation of patients' pain and symptoms. It is interdisciplinary as well. Patients do have to undergo a certification for a terminal diagnosis with 6 months or less of life expectancy. And they actually have to be recertified if they continue to live. Patients can actually get better on hospice and graduate from hospice, which is always a surprise when patients hear that. Patients have decided to end life-sustaining treatments, and their comfort is the priority. Medicare and most insurance companies do cover hospice care. A really important thing, though, to understand and think about when you're talking with hospice about patients is that the benefit does not cover room and board. So a skilled nursing facility with hospice, those patients have to pay for a skilled nursing facility room, which can be upwards of $10,000 a month. And so that's something really to think about when we're talking about what patients can access hospice care. Patients do have to have a certification of terminal illness, and if at home, families shoulder the burden of care, and we'll discuss that in a little bit. As I said, hospice is a healthcare service. It's delivered anywhere the patient is located. Little bit more like a physical therapy or occupational therapy. It is not a place. And I think that there tends to be this idea that hospice is a place. We're going to send them out to hospice and everything's going to be taken care of. But that's not how hospice works. And I'd like to share my experience. So this is John. John and I were married in August of my fellow year, 2017. He, in 2023, after we had dinner with one of my medical student mentees, had a seizure. He was diagnosed with brain inflammation. And I tell you, a seizure in the hospital is a lot less terrifying than a seizure at home. It is not an experience I wish on anyone. We went through John had a complex past medical history, and we ended up going to the Mayo Clinic for evaluation. He was already being treated there for some of his other illnesses, and he underwent a brain biopsy. And John had the best sense of humor, and he said 1 out of 10 do not recommend brain surgery. Interestingly, the thing that bothered him the most in the hospital was his arterial line. He said it was really painful. I've put in thousands of art lines over the years, and I've never considered whether it was painful to a patient. So that was really something that really struck me. 7 days later, while I was attending in the ICU, I got the diagnosis. I got the call from the neurosurgeon and said it was high grade infiltrative astrocytoma consistent with glioblastoma multiforme. In 2 days, I had made the calls. I had neuro-onc and rad-onc already consulted. And I have to say that being in a healthcare system where you know people, it makes it very easy to grease the wheels, so to speak. But it also made me very aware of how much privilege I have and how hard it is to navigate the healthcare system for patients who don't have that access. He started treatment on September 12th. One of the most amazing things that John's neuro-oncologist said in his first appointment was, this diagnosis will shorten your life. It is not curable. And so we knew very early that we were going to have to get hospice involved. I love this picture because John had a great sense of humor. He was on dexamethasone for the whole year, and he was always a very thin man, and he developed this steroid belly. And we were talking about how he looked like he was pregnant. And he said we were joking about doing a pregnancy photo shoot. And so we were in our living room just taking funny pictures. And then my phone did that automatic thing where it like pops it out and like makes it do a thing. I'm not tech savvy. But this picture, this is what the background my phone did to it. And it was just so perfect. So this was John's pregnancy belly. He was so surprised he had to go up on size on clothes. And but going back to hospice, when do you get hospice involved? I didn't know. What is a hospice? How do you figure out a hospice? How do you decide? What do we need to know? Hospice is this huge black box. And how long does it take to get to hospice, to bring in hospice, my takeaway was that I was woefully uneducated. I had recommended hospice to hundreds of patients, and I had no idea what that meant. It's really difficult, and there's a lot of emotions. Hospice agencies are like a physical therapy place in the community. The patient typically, if they're not inpatient, inpatient, you sort of have a social worker guiding things. But our palliative care team said, yeah, just call some hospices around, find the one you like, and let us know. We'll send the referral. So I'm literally Googling hospice Indianapolis, and you just have to shop around. Every hospice has to provide a minimal amount of coverage. That's what the Medicare requirement is. But different hospices have different selling points, just like anything else. And when do you decide that hospice is the right time? Remember, you have to decide that you're suspending curative intent. I ended up picking a hospice agency that one of my palliative care colleagues was a hospice medical director at. And one of the reasons I picked them was because their intake coordinator said, there's no rush. I'm going to have him on my list and I'll just call and check in if you need anything. And that was such a huge thing because she said, you do not need to enroll right now. We've already got all the stuff. He can be enrolled within 24 hours and I will take care of calling you. We enrolled on 7/1 of 2024. Again, I did not know what enrollment in hospice meant. I just knew we were stopping treatment. So what do you expect hospice to do? Is there like an army that rolls in and all of a sudden it's hospice? No. There's just a lot of paperwork. There's sitting at a table, reviewing medicines, going through paperwork, and not really knowing what the next step is. FMLA, I know the residents have to fill out FMLA forms sometimes, but it is a surprisingly difficult system. There's many options and the paperwork is hard. And when you're the caregiver, just figuring out that paperwork is so hard. And I remember as a resident just feeling so overwhelmed by this, but just remember that family member is so much more overwhelmed. Communication was really hard. You switch from palliative care, and then hospice and palliative care they just go away. So now you're telling all these new hospice people, as your loved one is dying, the entire history of your loved one. Because for reasons I don't fully understand, there is no cross communication. And so palliative care is fraught with some of the same issues that we see in our surgical patients and in our hospital patients. And patients really have to rely on community. This was me much of July of 2024. When you ask me how I'm doing and I say I'm functioning, this is what I mean. The supplies, we didn't know what was going to be given or provided, what medications are provided. What are your contingency plans for anything? And family and friends. And I think that my expectation was that hospice would do everything. And in reality, hospice sends a nurse once, maybe twice a week. There is a nursing aide who comes once or twice a week. Medications, they have to be mailed to you. Sometimes families have to go pick the medications up. So you are not going to have medications on hand immediately. And supplies, things like the stuff that we can do in the hospital, just go to the supply closet and get stuff. That supply closet doesn't exist at home. Urinals, chucks, wipes, basins, bedside commodes, shower chairs, wheelchairs, walkers, eventually a hospital bed. All of that stuff has to be brought in, and you just never know the right timing. And so being really thoughtful when patients are going home about what they really may need is really important. 2 weeks before John died, he decided he wanted to get a new cat because our cat Jasper had died 2 weeks before he went on hospice. And so this is Willow. This is a quilt that Dr. Bulger sent for John. And this was John at the end of his life. Willow understood what her job was and did not leave his side for the whole 2 weeks. She didn't get up from his bed. And she's an amazing cat. This was John. The second picture is John getting Willow from the Humane Society. He had never gotten to adopt an animal before, and it was really the only thing on his bucket list. And so 2 weeks before he died, he said, I want to go get a new cat. My brother-in-law took me into another room and said, do you think this is a good idea? And I said, no, this is a terrible idea. But if John wants a cat, John's getting a cat, and I'm going to have to figure it out. John had falls. I'm a freaking trauma surgeon. And I couldn't prevent my loved one from falling. If you see this bruise, you should think kidney laceration. John had a very big fall against the dresser and subsequently started having hematuria. What do? Do you take him to the hospital? He's on hospice. They're going to CT scan him. They're going to admit him, may put a Foley catheter in him. He hated having a Foley, very uncomfortable. What if PT said he wasn't safe to come home? So we made the decision to not go to the hospital. And me and my general surgery friend and the hospice medical director and my ER friend said, okay, we're going to treat this symptomatically at home. We're just going to hydrate and make sure he's voiding and watch his hematuria. And we think it'll be fine. I think it was. This looks like a really accessible shower. This was the shower in our downstairs bedroom. And I was like, great, this is so accessible. There's a pane of glass here. You can't tell that, but That makes it way less accessible all of a sudden. And unfortunately, it cut off with my fancy PowerPoint thing, but there's a ledge here. You can't wheel a wheelchair into this bathroom, into this shower, because there's a ledge. So how do you get someone who's variably mobile into a shower, and how do you get him washed? The nursing aide said, well, we'll just do a bed bath. I'm like, he doesn't, he was still conscious and talking. He's like, I don't want a bed bath. I don't want some strange lady wiping me down in bed. He wasn't bed bound. And the nursing aide said, well, I'm not getting in there. I'm not gonna get wet. I'm like, great. So now I don't even have bathing assistance. Uh, I've talked about some of this already, but safety is a big concern. What equipment? Toileting an adult is shockingly difficult. And I appreciate our nursing colleagues so much. But also, trying to get someone up to go to the bathroom is one of the biggest pieces of dignity that patients have. John really did not he did not like using the urinals. He did not like having to use a bedside commode. He really wanted to go to the bathroom. And we tried everything we can. We were having to use briefs. We don't have kids. I don't know anything about briefs. I don't know anything about diapers. I also had a really hard time, like rolling him and doing all of the like care things was really hard. And I one night was putting the brief on him and struggling, and I was trying to pull it up, and I gave it a big tug, and those briefs have tear-aside parts, and so it just tore. Like my hand just went, and I go, F. The real word, of course. And John looks over at me. He's on his side. He looks over at me and goes, that is not the sound of success. But how do you know these things? You just don't. And I'm really telling you all this because having a concept of what your patients' families are going to be going through, at least having an inkling of that road that they're about to walk, is so important. Care for patients in the hospital is easy. The nurses make it look so easy. I literally I called my ICU nurse friends and had them come teach me how to like rolls and drop sheets and boosting and putting pillows under under him so that he wouldn't like roll out of bed. I had this little wedge pillow because I have terrible GERD, and it actually worked out really well. He was able to stay in bed in our bed for probably a little too long, but it was a nice option. But then there's Willow again. Talk to patients and their families about garnering family and friend support. A lot of people don't want to burden their community. And sometimes even just saying, who can help you? Who can give you some support? And giving them that little thing to think about. How can they be supported? I was really fortunate in that John's parents were retired. We had room in the house. They lived with us for the last month. They lived with us most of the year, but his brother and sister-in-law were able to come. My sister was able to come, and then I had the best community in Indianapolis to help. So a couple of the residents came to see John. John loved resident education. He loved hosting journal club. He always thought it was so fascinating. And then these are some of our friends gathered around John, and then his brother and I giving him some care. And we were really fortunate. We had a house with room big enough to be able to have all of this in a room, and John was able to be comfortable in his room. John died on July 26th of 2024. We were only on hospice for 26 days. And it was the hardest month of my life. And I could only think, I cannot imagine my patients and their families who are doing this for months on end. It was exhausting. It was stressful. I do not remember a lot of it. A lot of this has been gathered from pictures that my family took, and I'm so grateful that they did. The mental strain that caregivers are under is completely underappreciated. And we frequently in kind of some of my support groups talk about widow brain, because you are really focused so much on the care of that person that everything else just goes to the wayside. I was crushing medications on our household mortar and pestle and giving him his meds and stuff. And finally my sister said, "When have you slept? Why don't you go take a nap?" And even with all these people there, even with everything going on, I felt so responsible. And so if you're in clinic with a sick patient or you're in the hospital, sometimes just saying to the loved one, "Are you sleeping? Have you been able to get some sleep? Need to take some time to go outside, take a shower?" That's really, really important because people forget about the caregivers. We're always focused on how the patient is doing, but the caregivers are suffering as well. This is my sister who came for a weekend and stayed for 2 months when she realized just how much I was struggling. These are John's parents. There's Willow, of course. That's my best friend. And we trained together. We were residents together, Karen. This is Ellie Curtis, who was also a trauma fellow here in 2017 and did palliative care as well. And then John's brother and sister-in-law. When John died, his favorite wine was Pinot Noir from the Willamette region. And so we had one of our loveliest bottles of Pinot to toast him. In conclusion, primary palliative care is an essential tool for every practicing surgeon. We have to focus on patient preferences, lived experiences, and perspectives. Palliative care specialists can help when goals are unclear. The patient or family is divided and symptoms are untreated. And palliative care works in tandem with referring providers to provide support and care. And I'm going to tell you, your experience for the residents here, your experience at UW using palliative care is dramatically different than other places in the country. UW has a very strong palliative care program and history. And a lot of what I learned about palliative care is work that I learned here as a surgical fellow. But as you go out into the world, that is not the case. There are hospitals without palliative care. There are places that we never consult palliative care. And so just to be aware of that, palliative care is underutilized in surgical specialties. Hospice is a subset of palliative care that aims to treat symptoms once curative treatment is no longer desired. It is not a place. It relies on extensive family involvement for care and may require out-of-pocket spending for placement. Families are not prepared for this reality. I did not know anything about any of this. And physicians in the broad sense, but surgeons particularly need to improve expectation management in the transition to hospice. I want to give my sincere thanks to the University of Washington Department of Surgery for training me in my first career, particularly Dr. Bulger, Dr. Meagher, and the trauma team at Harborview. The University of Washington Palliative Care Service has been fantastic as well. They have been amazing in training me, but also caring for my grief. And I have a whole other talk on managing grief that is we need to be kinder to each other is the upshot of that. Laura Buck and Jim Fausto are my primary mentors there. My family, John's family, and then of course John, because as hard as it is to give this talk, this is what he would want me to do with this experience. He really cared about education. He really loved, what I did. He donated his body to the medical school. And I had to clarify that his body was not going to end up one of the asset bodies. But he was very caring and giving, and he would be very proud. And I'm glad I got to share my pictures and some stories of him with you all. I'll take any questions.
Ashley, I just want to thank you for being so open and sharing your story. I heard you give palliative grand rounds, so I had a preview of this, and I think many people don't share their story, and we don't know what we don't know. So I just want to thank you for being that open, and I think it's a great testament to your resilience that you can channel this experience into making things better. We talked a little bit before Grand Rounds about a couple of the patients that we've been kind of co-managing at Harborview, um, who are young people with life-limiting issues. They need amputations, or they have long-standing wounds and things like that. Can you tell us a little bit about your thoughts about how we could do a better job of managing those types of patients in the hospital? They're in the hospital for sometimes months, and the team gets sort of frustrated sometimes in interacting with them because they start to try to drive their care in different directions. So can you maybe talk a little bit about your thoughts about how we could do better?
Absolutely. I think those patients can be some of the toughest because the lack of continuity of care really affects them, the patient's experience. And I think we tend to focus a lot on our personal experience, whether it's a week long attending, like that attending is taking care of that patient for that week. Or the month-long resident taking care of that patient. There are clear goals set out by the surgical team, but sometimes those goals aren't necessarily ever talked with the patient or made in conjunction with the patient. So we need to get her off. The comment is from the attending or the chief resident, we need to get her off morphine. The resident, the dutiful resident who is just trying to get things done is like, okay, we're going to wean off the morphine. I'm going to have it off by the end of the week. It's going to be great. I'm just going to change this order, and then that's going to be great. But we don't talk to the patient about it. We don't know what their experience is, what they're going through on the floor, and what that either that morphine dose is doing for them, or the need for it, or what the options are. Making choices in tandem with these patients, giving these patients time to consider their options. We tend to do a lot of stuff inpatient for these long-term patients, like very quickly, right? We want to do it this day. We want to do it that day. You're going to go to the OR today. You're going to go to the, whatever tomorrow. And those patients lose a lot of agency. And they lose the ability to go home and think about it, which patients who are in clinic get the chance to. So when you have a long-term patient, I think just work on patience. It is hard. I know you guys are busy. We are all so busy. But maybe saying, I'll take one less patient so that I can spend 5 more minutes with this patient. And maybe I'll just sit down and ask them what they like to do. How can we help them? Sometimes something like pain medication is, we just need to figure out a way that works for you. And if you work with the patients, a lot of times you can really overcome some of those issues. And then there really has to be a concerted effort to figure out a continuity plan so that the patient's care isn't changing every single week or month as new people come in and try to reinvent the wheel.
I have a few comments from the chat and then a question of my own as well. So thank you for sharing your story. That was a beautiful, heartfelt, and important grand rounds. Thank you for sharing your story, as difficult as it was. Incredible talk, wonderful presentation. Thank you for your candor and your bravery in sharing your John and mom's story. It's so impactful and appreciated. Thank you so much for a lot. There's a lot of comments about your wonderful talk and being so open and vulnerable and sharing everything that you've been through and that your family's been through. Um, and then also, oh, here's and then another one is, thank you for sharing such a challenging time in your life, showing us what happens on the other side um, of our recommendations, and sometimes they don't have their intended consequences when we give these recommendations. In caring for sick patients who are nearing the end of their cancer journey, it's often difficult to find a captain that can really engage with patients and caregivers at every step. How do you suggest that we do that as busy clinical providers, especially when we are struggling behind the scenes to find the right team to do this for them?
That's a really good question. I think it really just needs to be candor amongst teams. I'm on Montlake just finishing up here, and that is really a hard conversation. Who takes care of these patients once a decision is made, and how does that happen? And I know that it's a teaching service, and I know that residents have to continue to learn, but sometimes it just really needs to be a conversation between the attendings and the patient about going to sort of take over and switch and who's going to be running the program. I think really communication is the biggest thing. And I know we're busy, but you can also, with some focus, communicate a lot in 5 or 10 minutes. And that is really just so important for patients. I did want to add, I didn't share my mom's coda. My mom is still alive. She was found to have stage 4 disease when they went in for her surgery. She had pleural studding and was put on an immunotherapy. She chose the middle path. And she is still alive and on daily Tagrisso and beating the odds as a stage 4 lung cancer patient. So I'm now embarking on a journey as her caregiver with her new diagnosis of Alzheimer's. Sorry.
I echo everything that was said in the comments. Thank you for your beautiful talk. I had a question from your perspective as a caregiver and now as a palliative care provider on what you think is the appropriate time and how to introduce a palliative care consult to your patients, because, we don't always give a patient a heads up that, oh, medicine's going to come talk to you about your diabetes. But how do we kind of balance that without overstepping palliative care's role?
It's a really great question. I think that introducing palliative care as a subspecialty of medicine that provides caregiver and patient support in times of complex medical illness is a great way. Patients do have perhaps previous experiences or feelings about palliative care. They're going to get on Dr. Google immediately and Google palliative care. And so reaffirming that we are colleagues and we are medicine specialists, just like medicine, cardiology, and patients can say they don't want to see us. But a brief introduction, would you be okay in having an introductory meeting with them? And then that is a great way to sort of introduce us so it's not a surprise, but also to give the patients kind of that heads up. And I really do focus on we're there to support patients with complex medical decision making. So it is not about an end of life conversation at all. We're just there as this extra layer of support.
A question I had for you was, you had that Venn diagram when it showed coverage, and palliative apparently is not covered by Medicaid, Medicare.
It is, palliative care is just different. It is
Okay.
typically covered by Medicare. Some insurances may not cover it. Outpatient palliative care is a kind of a complex thing. It is covered. It's just a little bit different. It's not mandated. Like what hospice has to provide is mandated by Medicare, whereas palliative care is just much more like a medical specialty, like a cardiology appointment. So there's just not mandates.
I see. All right, thank you.
And Melanie has her hand raised online. I don't know if is there? I just saw the little.
Yeah, I don't think there's a way of.
Can you hear me, Ashley?
Yes.
Great. Wow.
Hi.
I just wanted to say thank you, as everyone else has, for your vulnerability. You had mentioned in the beginning of your talk that there will be no science in this presentation. I would just like to reiterate that I do feel as though these types of talks and experiences are far more educational than anything else could provide. So thank you so much. As a surgeon, I'm curious, and as now a palliative care provider, I'm curious, as you mentioned, as I experienced in my first few years out of training as a surgeon, we often do not have the support of palliative care colleagues like we do in big academic centers and in bigger institutions. What do you wish would change about surgical education to better prepare trainees for being primary palliative care providers and providing that continuity and discussions of prognosis that often only us as surgeons are able to do?
Thanks so much. And for everyone, Melanie is one of the new palliative care fellows at University of Washington this year. So we're really excited to train yet another general surgeon. And she's at Harborview Consults right now. So I think we have to create a surgical curriculum. There really needs to be a curriculum that integrates palliative care concepts into all of the subspecialties of surgery and really make it part of the practice, just like we make physical exam and differential diagnosis part of the practice. One of my biggest things when I used to staff consults is I would say, and what is their code status? And the resident would say full code. And I would say, is that because you asked or because you assumed? And eventually the residents did start asking because they felt bad about assuming code status. But it really does need to be a thoughtful, cohesive project. I think that there is still quite a bit of resistance to palliative care in some echelons of surgery. And so as the younger generation continues to rise with these educational endeavors, I think we'll get there. But
I'm not sure how to, oh, there we go. I'm Luis. I'm one of the medical students here. Hi. I also want to thank you for being so vulnerable and sharing your story. I think it's very educational for us as well. My question is, my family is currently navigating through something similar with my grandfather. I'm Mexican. And it's been very difficult to have like reliable access to culturally specific palliative care resources. So my question is, does the surgical teams have access to culturally specific palliative resources? Like, interpreters that are specifically trained in palliative and hospice care, or are we just relying on generalist palliative care to cover that gap?
There is no real specific care. Harborview has cultural mediators, and they can be very helpful, but they are not specifically trained in hospice or palliative care. I will say that those cultural mediators are fantastic because they usually are called in for the most difficult cases. But there's not really culture specific resources, and one of the things that I've really learned is that because of the cultural differences, we can't learn every culture, so we need to start training people within those cultures as palliative care physicians so that they can be specialists. We have a fantastic palliative care provider, Ryan Fong. I'm not sure if they're on here, but they're fantastic working with the Mandarin speaking community and some of the cultural considerations at end of life, with the some of the Asian cultures. And but unless there's a provider who sort of knows that background, there's really not anything specific that I'm aware of. It may exist, and I'm sure in places like Los Angeles it's probably more likely to exist, but I don't know of anything here.
Thank you so much for giving this talk. Something that I really struggle with is the whiplash when the attendings change on an ICU service, and the plans can go from, I expect this patient to like essentially die in a month, versus we can get them through this. And these conversations happen with family members, and the whiplash for me, I'm sure, is not as bad as it is for the caregivers who are there with the patients. And is there anything that you have experienced that can sometimes reduce that or improve communication at the attending level?
I wish I could. I really think that it has to be beholden on the attendings to communicate between themselves about things. Everybody's expectations are different, and expecting someone to make it through a month versus thinking they're going to die in a month. What does quote making it through mean? And so I think that's why we have to be really consistent in what are the if you put it on the patient rather than what we expect. What would the patient accept? Because are we talking about a trach and a peg and a 6-month LTAC stay? That is getting through it. Is that acceptable to the patient? So really thinking about having the patient and their goals and what the family is going through at the center will help align sort of what the teams are thinking.
Right, time for one last question here.
Hi, thank you so much for sharing your experience. The talk was excellent. During my research time, I worked on best case, worst case ICU. Dr. Schwarzy worked on that, and we did it at Harborview and ran into some challenges getting it kind of enacted on rounds. But I'm curious what your thought is on tools like this to kind of integrate palliative care concepts on rounds, and how some of these standardized tools could work or not work, and kind of what your experience is with them or the faults or benefits you see.
Struggle with standardized tools because patients aren't standardized. And so we can create these hypothetical scenarios where patients or families react really well to hearing that information on a daily basis. But some families don't find it helpful. Some families do find it helpful. Communication, preferred types of communication is highly variable. We also do tend to suffer from sort of a protocol overload in ICUs and clinical care in general. And so it is hard. Are we doing our ABCDF bundle? Are we doing our sepsis bundle? Are we doing our CAUTI bundle? Are we doing our palliative care bundle? And so I think that all of those have an amazing place. And I think that they're really good as sort of introductory teaching tools But once you become more facile, you really have to start again putting the patient in the center. And patients' best case, worst case is very different for patients, right? So, there are some people who think that death is okay, and some people who say death is the worst case. And so how do you align that is a really complicated thing. I think the screen went off, so I'm not sure if it kicked everyone off. And
Thank you so.
is there anything else on the chat, Colette? Just checking.
There's one last comment saying, I agree that there are very limited cultural specific palliative care resources and training diverse clinicians in palliative care is needed, but slow. Ultimately, recommend approaching each situation with an open mind and align families, even if we don't agree, and align with families, even if we don't agree, and then build rapport over time. Thank you so much, Dr. Meagher.
Thank you, everyone.